Thank you all for having me. Again, I wish I could be there with you and enjoy your wonderful country and fellowship. I was asked to talk today about allergic fungal rhinosinusitis in the United States perspective. Very interesting disease because I know that you see a lot of this in your part of the world, and I'd love to have discussions with you about the different observations and treatment modalities that we all employ. I'm Rakesh Chandra. I'm a professor in the Department of Otolaryngology at Vanderbilt University Medical Center. I'm the chief of rhinology, sleep and skull-based surgery. One of the entities which we're involved with is this Vanderbilt Allergy, Sinus, and Asthma program, where we collaboratively manage a lot of patients with these unique and difficult inflammatory diseases. So the typical history of this patient in the United States, a 44-year-old African-American male, 2-year history of nasal congestion that's usually worse on one side, in this case the right, also rhinorrhea and facial fullness, but without pain per se. Some loss of smell, no shortness of breath, conditions worse in the summer and fall. Frequently these patients are treated by primary care doctors with fluticasone and nasal spray and azithromycin, and unsurprisingly they don't help, and so eventually they end up in an otolaryngologist clinic after being initially seen in primary care. These patients typically are not febrile, and the physical exam, with a general physical exam, usually the patient will have what they describe as a nasally voice, but what they really mean is one that's hyponasal because of the lack of airflow and nasal resonance. Without an endoscope, all one would see is just a lot of snot in the nose, and some of these patients might have some slight wheezing, which is really by that I mean not a pulmonary wheeze, but a nasal wheeze from breathing air through tight nasal spaces. So a lot of these patients, empirically, before they get diagnosed, are treated with higher levels of antibiotics like amoxicillin, clavulanic acid, and prednisone, which does temporarily improve the sense of smell and congestion, but all too often after stopping those medications, the patients return to their baseline, and then they go through other cycles treated with other antibiotics and prednisone with essentially the same result. And it's usually after this ascending aggressiveness of medical therapy that in the United States, somebody sends the patient to otolaryngology, to a clinic like ours for further evaluation. And so we see this frequently in the part of the United States where I live, and a patient like this would have a nasal endoscopy like this with very large inferior turbinate with polyps and allergic mucin. In our Vanderbilt Allergy, Sinus, Asthma Partnership Clinic, we do a lot of multidisciplinary testing for aeroallergens, and this particular patient with positive to grass and mold mixture, cockroach, ragweed, we'll do spirometry. And in addition to our exam, which is nasal endoscopy, we'll also order the CT scan. It also amazes me that a lot of these patients walk around with some proptosis that nobody else seems to notice, but that when we see the patient, especially having knowledge of what the inside of the nose looks like, take notice of. It's nice to step back and think of the overall classification of chronic rhinosinusitis. The disease affects 35 million people in the United States, and it's defined as constant symptoms for 3 months, plus some objective evidence of the disease, either endoscopic or radiologic. A lot of work recently has been done in the field of endotyping chronic rhinosinusitis, looking at not just demographic variables and polyp status, but also cytokines. That's a little bit beyond the scope of this discussion, but to keep it in a more simplistic breakdown, that it's nice to describe patients with chronic rhinosinusitis as those with or without polyps. In the U.S., depending on what series you look at, about 30% of our CRS patients who are, at least the ones undergoing surgery, have polyps. And in that group, most of them have eosinophilic inflammation, but a lot of other endotypes have either mixed inflammation or some smaller but noticeable. Some of them do have neutrophilic polyps. These neutrophilic polyps are prevalent in eastern parts of the world. There are distinct syndromes that fall within this polyp-forming subtype of chronic rhinosinusitis, and one of those is the allergic fungal rhinosinusitis, which accounts for 10 to 12% of polyp cases. The non-polyp-forming chronic sinusitis, I'll just pause to say that there is a subset of CRS patients without polyps who do have eosinophilic inflammation that may really be on the spectrum to polyp patients. We are just seeing them early on. And then, of course, some non-polyp associated syndromes that are beyond the scope of this discussion. So the original definition of classic allergic fungal rhinosinusitis was defined a long time ago by Bent and Kuhn. It's still useful, where you need to demonstrate non-invasive fungus, eosinophilic mucin, and then in the patient you need to demonstrate an IgE response to fungi, whether that is with skin testing or serum testing. Either is acceptable. And then the patients need to have polyps themselves, as well as classic CT findings, which we'll discuss momentarily. So a better term for allergic fungal rhinosinusitis might be eosinophilic fungal rhinosinusitis, because the disease, is, at least in histopathologic terms, is more hallmarked by these eosinophils, and even though it's not really, there's still a lot to be known about the pathophysiology of this disease, but it's thought that this is probably a better hallmark of the disease than IgE-mediated allergy. What the arrows are showing you, well, you see the eosinophils here, but what the arrows are showing you is there's these Charcot-Leyden crystals, which are also a hallmark of eosinophilic inflammatory disease. Surgical findings or clinical findings, you've seen this, the diffuse polyposis with that tenacious peanut butter-like so-called allergic mucin. The radiology of this disease is very interesting, because most of our CT scans by default are done in bone windows, because it shows us the lamella of the ethmoid and the uncinate process very nicely using a very relatively low radiation dose protocol. In this coronal image, though, you see that this is not just your typical hyperplastic inflammatory opacification, as you have expansion into the orbit with some dehiscence of the medial orbital wall. You see these collections of hyperdense areas. The hyperdensity in this bone window is a little more subtle because it's bone windows, but if you look at a soft tissue window, this one in axial view, that these hyperdense areas are much more prominent and almost a metallic density. And the reason for that is that the fungal organisms, their cell walls chelate calcium and magnesium and give it that near metallic density. This is a very extreme soft tissue window, which shows these metallic areas very clearly in the expansion into the orbit. One interesting aspect of the radiology of this disease is that if you can get an MRI on a patient like this and look at it in T2 windows, and if you didn't look carefully, you would think that these sinuses are mostly empty. In this case, if you didn't notice the expansion of the maxillary here, you might just look at this part of the sinonasal anatomy and think these sinuses are empty. And that's because this allergic mucin and this fungal material is pretty devoid in water content. And so it becomes paradoxically blacked out in T2 weighted sequences. So let's talk a little bit about the pathophysiology of the disease. First of all, it's always fascinating to me how prevalent fungal organisms are in nature. They account for 90% of the biomass in soils. And in this disease, there's some interactive effect between the patient and his genetic predispositions and immune system, along with the environment. But it's important to note that you cannot eliminate fungi from your environment. They're prevalent in every ecosystem. Fungal spores are inhaled and can be isolated from the nasal cavity after 3 days of life. And the vast majority of these fungal species, fortunately, are not pathogenic in healthy humans. And then there's this concept, as I alluded to before, of both environment and antigen load in that environment, as well as the host susceptibility based on the immune and genetic makeup of the patient. This concept of antigen load, I think, is underscored by the geographic preponderance of the disease. And this mold counts vary by geography and season in the United States. It's not unsurprising that in a lot of these green shaded areas, we really don't see this disease as often, whereas in the darker shaded areas, again, this is in November, which is our fall. It's our cold fall months that it just shows the relative increase in prevalence in mold spores in these same areas where the allergic fungal rhinosinusitis disease also is more prevalent. This probably has to do with humidity. This is in my city. I'll go back a slide previously. My city is this asterisk here. We're part of the Great American Southeast, which is this part here. So in my city, humidity is upper average for the United States, and there you see that in the morning and then in the afternoon, compared to the average ranges for the United States, and we're in the upper ranges for both the morning and the afternoon, and that's throughout the entirety of the year. So the fungal species also vary geographically. So the humidity has something to do with it, but also in different parts of the country or the world, the types of fungi that are prevalent in AFRS also will vary. These pigmented fungus, the dematiaceous fungus or dark fungi, are seen more commonly in the U.S. associated with the AFRS. Those include Alternaria, which a lot of early studies from Mayo Clinic here showed that this may be the most immunogenic of these fungi. Also Bipolaris, which is seen very commonly in Curvularia. In other parts of the world, India, Pakistan, Middle East, it's thought that Aspergillus is more common, and we do see Aspergillus here as well. So fungi are very antigenic. The cell walls have a lot of compounds which can confer this, including chitin and various glucans. And a lot of people have allergy positive tests to fungi. About 10% of the population in the U.S. On skin testing will manifest some reaction to fungus. And about 30% of patients with clinical allergy, meaning that they actually describe symptoms of rhinorrhea and sneezing, et cetera, even a larger proportion of them, unsurprisingly, is sensitive to fungus. About 40% of asthmatics sensitive to fungus. And there is some family history here. This review is a nice reference to explore that further. So identifying fungal forms clinically is done on histopathology. Most microbiology labs in the United States have difficulty growing fungus, so that's why when we do surgical specimens, it's nice to take large clumps of that allergic mucin and ask the pathologist to stain it using this GMS stain, or this Grocott-Gromori methamine silver stain. As I mentioned before when we were talking about radiology, that these fungal cell walls take up metal ions, and so these silver stains highlight the fungus very well. This is Alternaria here, and these are the hyphae from Aspergillus. The hyphae from Aspergillus are branched and septated. So fungal sinusitis, this is a perspective thinking about, we're used to thinking about it in different ways under different clinical scenarios. Patients with immune suppression are getting disease from fungus invasion. These are your patients on cancer chemotherapy or folks with uncontrolled diabetes. These patients get what is really not a fungal sinusitis as much as it's an angioinvasive fungal disease. It's more, the angioinvasive part of that is actually more prevalent than the inflammatory reaction. Other forms of invasive fungal disease are pulmonary aspergillosis and disseminated aspergillosis. Over here on the left-hand side of the spectrum, whereas in this case you had immune suppressed patients, here you actually have hyperimmune patients, and these are patients where the host's inflammatory response is probably the more prevalent, what is the more prevalent part of the syndrome of the disease, more so than what the fungus necessarily is doing from a damage perspective. And in this category is allergic fungal rhinosinusitis, allergic bronchopulmonary aspergillosis, and then other various forms of fungal rhinitis and asthma, more garden variety forms. So the eosinophilic inflammation we mentioned here is the hallmarks, the inflammatory component of the disease, charcoal light and crystal there in magnified view. And this is what we think is happening, that there's there's a deposition of fungal antigens with higher antigen loading in certain geographic environments. This abnormally exaggerated post-inflammatory immune response with influx of eosinophils and inflammatory mediators. There's also evidence that fungal antigens themselves directly stimulate eosinophils. Then this induces the growth of polyps with osteal obstruction and stasis of secretions, and then further fungal growth. That mucin with the static secretions and fungal organisms and fungal antigens collectively become this allergic fungal mucin. So I talk more about eosinophils and less about IgE because unlike what was thought previously, and IgE may not be the whole story. And only 37% of cases in this series demonstrated fungal specific IgE when the mucin was present. Then also amongst those who appeared to have the full AFRS syndrome, meaning they had the mucin and the CAT scan and that looked classic and the polyps, that fungal specific IgE was more common. It was seen in 71% of those patients, but it wasn't universal. That means in patients who have what looks like classic AFRS, 29% of patients do not have fungal specific IgE in the mucin. And it's also interesting because some of these patients, even though you find it in the mucin, you don't find it in the serum. And so there's probably a lot going on here where IgE plays a role in the disease, but it may not be there at all in some cases, or it may be difficult to find, or there may be cases where we find IgE in the local mucins, but it's not seen in systemically. So if there's, of those Bent and Kuhn criteria, if there's one of them I'm willing to relax, it's whether there's a positive skin test or serum test to IgE. And if the rest of the criteria are there, then we will usually classify that patient as allergic fungal rhinosinusitis. So what other reasons might patients have for having negative allergy testing? Well, it's possible that these fungal organisms, particularly Alternaria, can directly stimulate the eosinophil without any need for antibody-mediated reactions. And then other things we talked about, that this IgE reaction could be local rather than systemic. And then there's also data from Australia looking at IgG3 as opposed to IgE as the fungal specific antibody. So this is really a mix of classic type 1 and probably type 3 mediated hypersensitivity. But the prevailing issue, at least looking at the tissues in the mucin, is this exaggerated maladaptive eosinophilic response that is could be directed directly to the fungus, or could be primed directly by the fungus, really is a better way to say it. So how do we manage these patients? In principle, this involves various combinations of steroids and surgery and immunotherapy. The surgery is a cornerstone of the disease, but without medical therapy and also environmental control, this tends to recur. Under the medical heading here, I have both steroids and antifungals in parentheses. I'll talk a little bit more about that later, I think, but the steroids are really the workhorse of that, and the use of antifungals is all but fallen off in the United States these days. Immunotherapy, again, I think I'll address that a little bit more later. Now, I do want to pause and say, because allergic fungal rhinosinusitis is more prevalent in humid climates, that we think that this ambient fungal load affects susceptible patients, that patients are encouraged to avoid environments where there's expected to be a lot of humidity, avoid environments where there's thought to be a lot of soil in the air, and moist, damp basements are a good example, and also to dehumidify the home to keep the relative humidity less than 50%. So with those other treatment modalities, as far as what's based on data, that except for surgery and steroids, prednisone, the rest is really debatable. The role of oral and topical antifungals is controversial. There's very little data specifically in allergic fungal sinusitis. And there's also toxicities with these drugs. So when something has potential toxicity and lack of relative efficacy, we tend to use it less. The Cochrane reviews and this Jackie article are great references there. Immunotherapy, allergy shots, is conventional in the treatment of this disease, but the data behind it is, and the robustness of its value is not on par with what we see with surgery and steroids. Still, in most of these cases, the risks of immunotherapy are small, and so we tend to apply it. It's a conventional part of the disease management that we think does improve long-term outcomes, but again, that's not demonstrated statistically. It's more an observational thing. So my perioperative algorithm that these patients historically would receive prednisone 30 to 40 milligrams a day, depending on the size of the patient, for 5 to 7 days preoperatively, and then do full house endoscopic sinus surgery. All of that polyp tissue and all of that mucin needs to be removed. Postoperatively, I keep patients on 20 to 30 milligrams a day postoperatively until the disease resolves endoscopically. This can take a month, it can take 2 months. Sometimes we end up stopping it a little before there's endoscopic resolution because the patient starts to have, gain weight and have steroid intolerance, and we have to just try to wean it off. If patients do need to be on steroids for more than a couple weeks at a time, it's always nice to give them proton pump inhibitors to protect the stomach, and superimpose with this, they're on saline rinses and having the sinuses debrided in the office setting. So that's sort of the classic algorithm. That full house endoscopic sinus surgery, all of that inflammatory tissue needs to be removed. The mucin, which has both fungal antigens and eosinophils, all needs to be extracted. It can be very frustrating and painstaking to do that. The purpose of the surgery is not just to remove the disease, though, but it's to create pathways for local drug delivery and irrigation. In these cases, the image-guided surgical navigation is very helpful because, as you saw before, there's a lot of distortion of the orbit and skull base with bone demineralization and sinus expansion. This is just an example of that. And this is a bone window, so you see these, you have to look carefully for these hyper dense areas, and you see the bowing of the ipsilateral orbit there. The mucin in these kinds of cases, if you think back to what we talked about with the pathophysiology of the disease, that the hyperinflammatory polyp growth that obstructs sinus ostia causes further retention of the mucin, which has the eosinophils and the fungal organisms embedded in it. And it's the products of the eosinophil, like the major basic protein that spill out onto the tissue that further amplify the inflammation. And it's those eosinophils and their products that need to be removed as part of these steps. And then the fungal organisms, which are the original antigenic drivers, are also needing to be removed. And this is very painstaking because that eosinophilic mucin is very adherent to the tissue, it's very sticky to itself. And so a lot of times that actual dissection, the polyp removal, is not the difficult part of the surgery. It's extracting all of this stuff. So as I mentioned, tapering off the oral steroids usually after a month. Sometimes the inflammation is not quite resolved at that point, but the patient by about a month isn't tolerating being on oral steroids anymore. Once we've tapered off the oral steroids, or once we start tapering off the oral steroids, nowadays we also start patients on steroid irrigations and have them use either budesonide or mometasone with the saline. If patients start to exacerbate, we have a liberal use of putting them on oral steroid bursts again. These patients, every 1 to 3 months for even a year, need to come in and have cleanings done, because as they tend to reaccumulate allergic mucin, that needs to be promptly extracted. We start allergy immunotherapy shortly after surgery, and only in unique cases would we use antifungals. I would tell you nowadays that the use of them is almost never. So topical steroid irrigations are kind of default prescription in these cases is to use budesonide, and because it comes in these respules that are marketed for use in asthma nebulization, but they're pre-prepared in measured doses. Actually, you can get them up to 1 milligram per 240 milliliters. They're not specifically studied in AFRS, but they're used because the topical steroid is generally considered safe. We have patients take 0.5 milligrams, which is in what's in one of these ampules, and add it to the NeilMed sinus rinse bottle, which is 8 ounces or 240 cc's, and irrigate twice daily. There's a couple studies, but one of the best ones is one you see referenced here, shows that there's really no significant suppression of stimulated AM cortisol. It was seen in 11 of 48 patients, but all of those patients were also on inhaled corticosteroids for asthma. Also, it reverted to normal after stopping therapy in 3 of the 4 patients who had follow-up studies, and in none of the 48 patients was there any overt adrenal suppression symptoms or changes in intraocular pressure. So we think this is safe, and so when we have a therapy where the theoretical benefit is there and where it's been shown useful in other similar, albeit less severe disease states, with no real concern for major side effects and complications, then we employ it. Antifungals, as I mentioned, that there's early preliminary data in case series, but lacking controls. There are a couple studies. This one, interestingly, was from my state from almost 2 decades ago, showing that there is some role in reducing steroid needs and reoperation. But again, this is an observational, non-controlled study. The only one real randomized controlled study in the area was published by Kennedy, looking at terbinafine, which was otherwise used for toenail fungus in the U.S. This is oral terbinafine in 53 patients. Originally, the patients for inclusion into the study needed to have positive fungal cultures, but towards the end of the study, that criteria was relaxed when it became clear that it can be difficult to actually grow fungi in the lab. And bottom line is, it didn't work. That in the one randomized controlled study, there was no improvement in either symptoms or CT appearance. So why, you might question why antifungals don't work, at least they don't work all that well. Probably has to do with those 2 same factors, that the fungi are ubiquitous in the environment and that the main problem is the host inflammatory response. One trend that you might see in some areas, it's not part of my practice, but one trend you might see is using amphotericin B irrigations, because the amphotericin B delivered in that method, even if it might not work, that because there's no systemic effect, it might have an accepted risk to benefit ratio. But again, I'm much more interested in the patient irrigating with steroids. So immunotherapy, some early studies, these are observational studies, showing that treating both fungal and non-fungal antigens can improve the endoscopy findings and lessen the need for oral and topical steroids. But it's important to note that the immunotherapy is pointless if you have not first remove the burden of the disease by surgically resecting the polyps, which is amplifying the disease in situ as it becomes repositories of eosinophils and IgE, and then also we're extracting all that allergic mucin, which also contains eosinophils and the fungal antigens. So some new directions in the United States include use of these monoclonal antibodies, and we have the most experience with this one, which is Dupilumab. It's a subcutaneous injection patients give themselves every 2 weeks at home. It blocks the alpha subunit of the IL-4 receptor. And so there's this IL-4 receptor has this alpha subunit, and it's blocked. It turns out IL-13, which is another cytokine involved in that eosinophilic type inflammatory disease, also has that alpha subunit, and it blocks that as well. So this blocks both the I'm sorry, it's this one here. So it blocks both this IL-4 and this IL-13 receptor. There are different types of IL-4 receptors, and there's different types of IL-13 receptors, but pretty much except for this decoy IL-13 receptor, which we've not even known the function of, the rest of them all have this alpha subunit, and so that's why this is a pretty potent drug, knowing that these IL-4s and IL-13s are key cytokines in that eosinophilic inflammatory pathway. So this is just showing some of the effects of IL-4 and 13, that in addition to eosinophils, they also drive local production of IgE by B cell class switching to this IgE secreting, and also effects on mucus production. IL-13 especially has a lot of effects of mucus production, and other indices of airway inflammation and hyperresponsiveness. This was published in Lancet with a large series of authors, very high impact publication, and it's a series of patients across 2 randomized controlled trials that they were either receiving Dupilumab or placebo every 2 weeks for 24 weeks. All the patients in these trials received intranasal mometasone. 70% of these patients had previous surgery, and they all had improvements in asthma control. Well, collectively, there was significant improvements in asthma control indices, as well as polyp size, congestion, and sense of smell. So my current algorithm has changed from that one that I had shown you originally, where nowadays this pre-op prednisone, we don't necessarily give it. And a lot of that is because we're using 1 to 1,000 epinephrine for surgery, and so pre-treating with prednisone in order to control operative blood loss is less necessary. These patients are given doxycycline postoperatively, even though this is not a bacterial infection, because doxycycline has some data showing that it suppresses indices of eosinophilic inflammatory disease. These patients get surgery like we talked about. They're on prednisone postoperatively like we talked about, which is then gradually weaned. As they're on longer courses of prednisone, we also put them on a proton pump inhibitor. We start them on steroid irrigations, but instead of budesonide, nowadays I use mometasone, which we obtain from a compounding pharmacy. Mometasone is stronger than budesonide, and it's less bioavailable, meaning there's less systemic absorption, and it's also got more data behind it for control of the type of inflammatory disease seen in this condition. And then post-operatively at some point, and you can actually do that any time, but by convention we usually just start it once we're starting to wean the patient off steroids. We put the patient on Dupilumab. So that really can be done any time here, but sometimes even preoperatively. But usually by at least the 3rd post-operative visit, 3 weeks post-operatively, we want to have that patient on Dupilumab, and we try to have it initiated at least by then, so we can then start weaning the oral steroids, and all the while the patient's on a steroid irrigation. So with that, I'd like to close the session, and if you'd like to come visit our department or contact me, here are ways to do it. Thank you again very much.